Good afternoon, everyone. My thanks are extended to the panel, the audience coming in today for a short and sweet lecture, and to Mr. Chairman. Our topic is going to be about enteral nutrition's role in Crohn's disease. As a rule of thumb, patients with Crohn's disease are considered critically ill, and accordingly, that being the basic point, the first question we will ask when considering enteral nutrition or any form of nutrition support is the patient malnourished or at risk of malnutrition? If the answer is yes, the second question will immediately be, do we have a gut valid to work? If the answer is yes, start immediately enteral nutrition, whether tubal or oral. If the answer is no, now we will consider parenteral nutrition. Why did we consider the patient critically ill? Because of the consequences of malnutrition in patients with Crohn's disease. We do understand that patients with Crohn's disease have a very high potential of weight loss, especially the lean body mass, which happens in over 10% of cases. This will increase the incidence of morbidity, secondary to poor healing and increased incidence of infection. And the reason behind this is basically mediated by lack of physical activity among patients with Crohn's disease, as well as the inflammatory mediators, which end up giving the patient a sense of anorexia. There is poor absorption and digestion, and accordingly, a decreased intake of meats. Number two will be the bone diseases, which is actually multifactorial when it comes to the etiology underlying it. And it's basically due to the glucocorticoid therapy, the inflammatory mediators, which again lead to malabsorption and maldigestion, and in turn, a decrease in the intake, as well as hypogonadism. Micronutrient deficiency is the third consequence of Crohn's disease, due to energy expenditure being higher than normal, malabsorption and excessive loss, anorexia and decreased intake, and of course, a delayed growth and retarded growth and delayed puberty among children. Now, according to this, we're going to assess the nutrition status of the patient through two things. Number one, diagnose undernutrition, and number two, have some tools available in order to have a correct diagnosis. Diagnosing undernutrition through history, physical examination, BMI, and do a body composition. Anything you can do in order to assess your patient clinically, especially that we are all going to be either clinical or paramedical personnel doing this. Assessment tools will include specialized tools for nutritionists, such as the subjective global assessment and the MUST. This is something kind of specialized. Nutritionists and dietitians will be able to apply. And the other two include dietary and laboratory. Okay, so what is the dietary tool assessment? In general, the dietary assessment aims to identify any item that will either trigger activity or, on the contrary, something that if you remove will improve the status. We can do this through 24-hour dietary polls, diaries of 3 to 4 days, or questionnaires. And there's some dietary assessments to be carried out specifically to kind of pinpoint specific manifestations related to the Crohn's disease itself that might enhance or increase the malnutrition. Now, this part could be carried out by a nutritionist or a dietitian. What about the laboratory monitoring? It depends basically on disease activity, clinical status of the patient, location of the disease, general condition of the patient, any specific risk disorders. There are routine monitoring that we do every 6 to 12 months on regular basis, unless the patient is to be followed up. So maybe you need to do it frequently. For example, on enteral nutrition or parenteral nutrition, the patient is young in age and needs to increase the frequency of following up, or sometimes if there is activity. The regulars that we do are CBC, we do segmentation rate, C-reactive protein, serum albumin, and vitamin D. While if the condition is more aggressive, severe activity, short bowel syndrome, severe malabsorption, intractable diarrhea, then you want to go into deeper investigations such as the ferritin, serum iron, zinc, calcium, sodium, potassium, magnesium, phosphorus, folates, B12, and so on and so forth. Are there certain risk factors that will increase the possibility of nutrition deficiencies? Absolutely. I think the most important is the disease location. If the disease is involving terminal ileum, you're going to have definitely the fat-soluble vitamin deficiency in addition to B12 deficiency. While a proximal small intestine involvement will end up with iron deficiency and calcium deficiency due to malabsorption. If it's a diffuse, you have both in addition to zinc deficiency and other kind of trace element deficiency. Severe colonic disease will add bleeding and inflammation, which will add to the severity of iron deficiency. Disease activity, of course, because of the inflammatory interleukins and mediators, which will increase the anorexia, will increase energy expenditure, will increase the sense of distension, intolerance, diarrhea, and so on and so forth. Of course, malabsorption and excessive loss. Age, growing children need more intake and will be more vulnerable to nutrition deficiency. Surgical resection, it's the same thing. If you're removing the terminal ileum, you end up with certain consequences, and these consequences may reach up in short bowel syndrome cases up to severe steatorrhea and choleratic diarrhea with severe deficiency of most of the micro and macronutrients. So now we decided to introduce ourselves to the patient with a nutrition support plan. In order, our rationale here is to basically improve the nutrition status and avoid any diet targets or triggers. And the route will be either enteral, oral, tubal, or parenteral, or sometimes even a combination. So let's focus on enteral nutrition. What is the exact role of enteral nutrition in patients with Crohn's disease? I'm going to classify it into patients with undernutrition, patients with no malnutrition or undernutrition. The aim of enteral nutrition here in a patient with undernutrition is to replenish the deficiency of calories and proteins. It's usually given in the form of a liquid formula, and this is what we call recently exclusive enteral nutrition. It's one of the best techniques to use when you're starting, especially with a patient in activity or a patient with severe malnutrition. You will plan according to the weight, and you are going to do the calculations according to the weight. So we do know exactly how much the patient needs, and accordingly we will introduce such nutritional therapy through an enteral tube or oral feeding. Sometimes all what you need is a supplementary enteral nutrition. So the patient is on oral diet, but you will help with a supplementary. What if the patient does have Crohn's disease, but there's no malnutrition? Look at the status. Is there active disease? If that's the case, the main thing is look at any item of food that if introduced will trigger, if removed will improve. Some people feel that using FODMAP diets like that of irritable bowel syndrome could help, and some people get better results if you do what we call lactose restriction. What about a patient without undernutrition and in remission? Basically, follow a healthy diet. Carbohydrates, proteins, fats, decrease processed foods, no artificial sweeteners, avoid trans fats. Other techniques, yes, there are other techniques and interventions. Some are of unclear benefits, some are of very clear benefits. Let me start with the easy ones. Fiber. Should I give the patient fiber or not? The question is never restrict fibers except if you have a patient with a stricturing disease. What is the amount that it's kind of optimal? 14 grams for every 1,000 kilocalories. Okay, that known. Why do we want to give fiber? Because fibers help the commensal bacteria, the good bacteria in the gut, and number two, some of them, when they are metabolized, they release the short chain fatty acids, which help absorption of sodium and potassium in the colon and healing of the mucosa. Supplemental enteral nutrition, we just mentioned it. Beside biological therapy, beside regular diet, you can always add some kind of a supplemental enteral nutrition, whether oral or tubal. Other options, and I'm going to underscore the exclusive enteral nutrition plus other items. Exclusive enteral nutrition is a technique that has been surfing recently, one of the best. It's actually considered a primary line of nutrition support in children and adolescents, especially with induction therapy, where we introduce only liquid formulae, whether it's polymeric, elemental, semi-elemental, it doesn't matter. The choice here depends on the tolerance, the acceptance of the patient, the cost, the physician's decision, and nutritionist's decision. What we do is we introduce the liquid, no solid diet. The liquid diet takes about 6 to 12 weeks in order to build up. It's an average of 8 weeks. We start gradually through 3 to 4 days, and then we start to introduce the solid food gradually. It does really give very good results, especially among children and adolescents, and it does reduce the need for glucocorticoids. Other techniques such as elimination diet, and we covered this already. Some people will claim that eating certain item triggers the attack and removing certain item will improve it. Well, it's not really always the case, but I would respect such a thing and maybe try to eliminate some items and then introduce it carefully and cautiously. Some people believe the premise that the carbohydrate metabolism releases a lot of toxins and acids that kind of increase the ulceration, the pain, the inflammation, and accordingly, they kind of promote the idea of giving a very specific, very low carbohydrate diet. It's usually grain-free, lactose-free, sugar-free, sucrose-free, does not allow any processed food. There's meat, there's some legumes, some nuts, some fruits, some vegetables, homemade yogurt, low lactose intake of cheese like cheddar cheese. But again, it's not one of those acceptable. It's not tasty, it's not good. Others include probiotics. I personally, in my personal experience, I see very helpful during diarrhea. But again, there are no recommendations for or against. Same thing goes with fish oil and antioxidants. They're very good to boost the immune system. But again, their substantial data are not that substantial enough to act for or against. In other words, real recommendation of yes or no is not there, not substantial. But we do give them, it helps with healing, with a little bit of boosting the immunity in a way. What about some populations in specific? If you have an obese patient, treat and apply what we just mentioned. In children and adolescents, please focus on the importance and the risk of malnutrition and weight loss. These children benefit a lot during induction therapy from what we call exclusive enteral nutrition. Always remember, you can modify, you can do what we call supplemental enteral and regular, supplemental and biological. You can always modify. Having a nutrition support team among your team will help you a lot to decide. Patients with surgery or going into surgery are less lucky. Those patients probably have serious disease and are at a very high risk of malnutrition. We recommend usually giving parenteral nutrition, especially in the period before surgery. So in a nutshell, we need to identify our patients at risk or with malnutrition, assess the nutrition status with different techniques mentioned before. For patients with Crohn's disease and undernutrition, consider enteral nutrition, whether oral, tubal or not, and then discuss enteral nutrition with a nutritionist, whether they want to use exclusive enteral nutrition, whether they want to implement supplemental, whether they're going to give a combination of oral and tubal. A decision could be made by a good nutrition support team. Most patients with Crohn's disease in remission, if they're able to sustain enough intake, that's enough. If not, just add a supplemental enteral nutrition. Do not restrict fibers except if there's a stricturing disease. Remember, a healthy diet is your key word. It's the key word in all cases. If the patient has short bowel syndrome, severe kind of malabsorption, you might need to consider parenteral nutrition. And I thank you very, very much for being here and for listening. Thank you.